Pathophysiology. In T1DM, there is cellular-mediated, autoimmune destruction of pancreatic beta cells. T1DM has a strong genetic predisposition. The major histocompatibility complex, MHC, also known as human leukocyte antigens, HLA, is reported to account for approximately 40 to 50% of the familial aggregation of T1DM. The significant determinants are polymorphisms of class II HLA genes encoding DQ and DR4, DQ8, with DR3, DQ2, found in 90% of T1DM patients. Another form of T1DM is latent autoimmune diabetes of adults, LADA. It occurs in adulthood, often with a slower course of onset. The rate of destruction is generally rapid in children and faster in adults. Autoantibodies against islet cells, insulin, glutamic acid decarboxylase 65, GAD 65, and zinc transporter 8, ZNT8, may be detected in the serum of such patients. These antibodies wane over time and do not have sufficient diagnostic accuracy to be used routinely for diagnosis, especially after the first year. With the progressive destruction of beta cells, there is little or no secretion of insulin. These patients are generally not obese. They are more prone to develop other autoimmune disorders such as Addison disease, Graves' disease, Hashimoto thyroiditis, and celiac disease. A subset of T1DM not associated with insulin autoimmunity and not associated with the above HLA is termed idiopathic T1DM. It is more common in African and Asians and presents with episodic diabetic ketoacidosis, DKA. T2DM is an insulin resistance condition with associated beta cell dysfunction. Initially, there is a compensatory increase in insulin secretion, which maintains glucose levels in the normal range. As the disease progresses, beta cells change, and insulin secretion is unable to maintain glucose homeostasis, producing hyperglycemia. Most of the patients with T2DM are obese or have a higher body fat percentage, distributed predominantly in the abdominal region. This adipose tissue itself promotes insulin resistance through various inflammatory mechanisms, including increased FFA release and adipokine dysregulation. Lack of physical activity, prior GDM in those with hypertension or dyslipidemia also increases the risk of developing T2DM. Evolving data suggest a role for adipokine dysregulation, inflammation, abnormal incretin biology with decreased incretins such as glucagon-like peptide 1, GLPI, or incretin resistance, hyperglucagonemia, increased renal glucose reabsorption, and abnormalities in gut microbiota. History and physical. Patients with diabetes mellitus most commonly present with increased thirst, increased urination, lack of energy and fatigue, bacterial and fungal infections, and delayed wound healing. Some patients can also complain of numbness or tingling in their hands or feet or with blurred vision. These patients can have modest hyperglycemia, which can proceed to severe hyperglycemia or ketoacidosis due to infection or stress. T1DM patients can often present with ketoacidosis, DKA, coma as the first manifestation in about 30% of patients. The height, weight, and body mass index, BMI, of patients with diabetes mellitus should be recorded. Retinopathy needs to be excluded in such patients by an ophthalmologist. All pulses should be palpated to examine for peripheral arterial disease. Neuropathy should be ruled out by physical examination and history. Evaluation. Screening. Persons older than 40 years of age should be screened annually. More frequent screening is recommended for individuals with additional risk factors for diabetes. Certain races/ethnicities, Native American, African American, Hispanics, or Asian American, Pacific Islander. Overweight or obese persons with a BMI greater than or equal to 25 kg per square meter or 23 kg per square meter in Asian Americans, first-degree relative with diabetes mellitus. History of cardiovascular disease or hypertension. Low HDL cholesterol or hypertriglyceridemia. Women with polycystic ovarian syndrome. Physical inactivity. Conditions associated with insulin resistance, for example, acanthosis nigricans. Women diagnosed with gestational diabetes mellitus, GDM, should have lifelong testing at least every 3 years. For all other patients, testing should begin at age 45 years, and if results are normal, patients should be tested at a minimum of every 3 years. The same tests are used to both screen for and diagnose diabetes. These tests also detect individuals with prediabetes. Diagnosis. Diabetes can be diagnosed either by the hemoglobin A1C criteria or plasma glucose concentration, fasting or 2-hour plasma glucose. Fasting plasma glucose, FPG. A blood sample is taken after an 8-hour overnight fast. As per ADA, fasting plasma glucose, FPG, level of more than 126 mg per deciliter, 7.0 mm per liter, is consistent with the diagnosis. 2-hour oral glucose tolerance test, OGTT. In this test, the plasma glucose level is measured before and 2 hours after the ingestion of 75 gm of glucose. DM is diagnosed if the plasma glucose, PG, level in the 2-hour sample is more than 200 mg per deciliter, 11.1 millimoles per liter. It is also a standard test but is inconvenient and more costly than FPG and has major variability issues. Patients need to consume a diet with at least 150 g per day of carbohydrates for 3 to 5 days and not take any medications that can impact glucose tolerance, such as steroids and thiazide diuretics. Glycated hemoglobin, HB, A1C. This test gives an average of blood glucose over the last 2 to 3 months. Patients with a HbA1c greater than 6.5%, 48 mole/mole, are diagnosed as having DM. HbA1c is a convenient, rapid, standardized test and shows less variation due to pre-analytical variables. It is not much affected by acute illness or stress. HbA1c is costly and has many issues, as discussed below, including lower sensitivity. HbA1c should be measured using the National Glycohemoglobin Standardization Program, NGSP, certified method standardized to Diabetes Control and Complications Trial, DCCT, assay. It is affected by numerous conditions such as sickle cell disease, pregnancy, hemodialysis, blood loss or transfusion, or erythropoietin therapy. It has not been well validated in non-white populations. Anemia due to deficiency of iron or vitamin B12 leads to spurious elevation of HbA1c, limiting its use in countries with a high prevalence of anemia. Also, in children and the elderly, the relation between HbA1c and FPG is suboptimal. For all of the above tests, if the person is asymptomatic, testing should be repeated later to make a diagnosis of diabetes mellitus. In patients with classic symptoms of hyperglycemia, increased thirst, increased hunger, increased urination, random plasma glucose more than 200 mg per deciliter is also sufficient to diagnose DM. FPG, 2-hour PG during 75 g GTT, and HbA1c are equally appropriate for the diagnosis of DM. There is no concordance between the results of these tests. Diagnosis of gestational diabetes mellitus. Pregnant women not previously known to have diabetes should be tested for GDM at 24 to 28 weeks of gestation. ADA and American College of Obstetrics and Gynecology, ACOG, recommend using either a 1-step or 2-step approach for diagnosing GDM.